Good morning. My name is Kristen Talbot. I am the program manager for MAVEN Project. Thank you all for joining us today and our friends at Generations Family Health Center for hosting today's session, Care of Transgender Patients, Gender Affirming Hormones with Dr. Carrie Horwitch. Dr. Horwitch is an outpatient primary care physician. She's also a certified specialist in care for patients living with HIV. She's been in practice for over 30 years. For 20 years, she worked with the Virginia Mason Medical Center Internal Medicine Residency Program as an Associate Program Director and key clinical faculty. She's a clinical associate professor of medicine at the University of Washington, Seattle, and we're just so very lucky to have her as a MAVEN Project volunteer. So with that, I will share your screen.
Thank you so much, Kristen, and good morning, everybody. Thank you for joining this talk. Let's go ahead. So the first two slides are just reaffirming I have no financial disclosures, and you already heard about the CME. So my personal disclosures that I think is important to mention are that all gender-affirming hormone therapy is actually considered off-label use and has not actually been approved by FDA for these purposes. I am only an adult physician, so I will only be talking about gender-affirming hormones from the standpoint of adults, which means over 18 years old, so not any of the children going through puberty. I am not an endocrinologist or a surgeon, and a lot of the data I will be presenting is both based on research, which is growing but still limited, so there is a lot about just expert opinion, and that's why you may find different guidelines when you look online. Next slide, please. So what I hope we will accomplish today is that just to develop a little bit of an awareness of some of the challenges that face transgender patients in the healthcare environment, how to identify gender identity concerns, discuss some primary care issues for transgender, discuss initiating or continuing gender-affirming hormones, and then a little bit about some of the risks and changes that can occur with these hormones. Next slide. So in terms of epidemiology, again, it may depend on what definition you use for someone who identifies as transgender, but there's approximately 25 million people worldwide who identify as transgender and approximately 1.6 million in the United States. So that's less than 1% of the population. But again, those may be underestimates because a lot of people don't disclose because of fear of how they may be treated. Next slide. So there was a survey that was done of patients who were either gender nonconforming or transgender and found that at least a third had had a very negative experience with a healthcare clinician in the past year. 23% would not see a doctor because they felt that they could be mistreated. Almost all 3/4 or more actually would want hormone therapy, but less than 50% receive it. And about a third reported that their clinician doesn't even know that they are transgender. Next slide. So they do need our help. And there was, again, the same survey that talked about some of their healthcare issues showed that almost 40% actually experience psychological distress, which is much, much higher than the general population in the United States. 40% have attempted suicide. Again, comparing that to the average US population is much higher. And there are studies that show that gender-affirming hormone therapy can actually improve depression, anxiety, psychosocial functioning, and many other issues. So it is important to, if a patient opens up, that they believe that they are transgender and want hormones, that having the conversation with them in a, an open environment in healthcare can be very important. Next slide. So let's go through a few definitions just to clarify. So gender identity is how a person perceives their gender. Gender dysphoria is still in the DSM diagnosis, but that is really limited to those who have severe distress caused by the feeling that their birth gender does not match their current identity. And I want to point out that not everyone who is transgender actually has gender dysphoria by its definition. A trans male is someone who is assigned female at birth, but identifies as male. A trans female is someone assigned male at birth, but identifies as female. Non-binary is someone who really doesn't identify as male or female. A cisgender is somebody who identifies with their gender at birth. And this is to distinguish it from sexual preference, which is actually what sex or body part someone prefers to use for sexual contact. So gender identity and sexual preference are not the same thing. Next slide. A few terms not to use and preferred use. So when you are talking with or discussing someone who has a gender, wants to discuss their gender identity, use their preferred name and pronoun. And if there's a way to put that into your electronic health record, that helps. The terms to use are transgender, a trans woman or just woman, trans male or male. We don't use the verb form, so nobody is transgendered. Transsexual is not the correct terminology either. Saying someone's born a man or woman is different than what their assigned sex at birth is. And sex change is also not accurate to use. So it's important when you're writing your notes to use the more appropriate terminology for that. Next slide. So why are there so many barriers? Again, most clinicians have actually no exposure or education on transgender care. Most of the hormones are off-label use for this. There really is no true specialty for transgender patients. Many times it's in primary care, endocrinology, and other specialties, OBGYN sometimes. And so really it's up to the individual clinician to get trained into this care for themselves. And there are more courses, classes, and education online now than there used to be. Our systems are not always affirming or inclusive. That could be signage. It could be our bathrooms. It could be our electronic health record that only allows the official name of a patient rather than what they preferred to be called. So there are many barriers to making it more accessible for our patients. And again, there may be, of course, clinicians and systems that actually have a bias regarding gender identity. And I think our current political situation has shown or highlighted some of these system issues that we see. Next slide. So what can we do to set up the visit? And I do want to just say that if you have questions, please put them either into the chat or the Q&A. I will try to get to them as we go along or wait till the end of the talk. I will make sure we leave time. So when I set up a visit, and this is pretty much true of every patient, I try to introduce myself. I ask the patient how they prefer to be addressed and if they have preferred pronouns. I usually try to do my full history when someone has their clothes on and not already in a gown. And I always do agenda setting for every patient for that visit. Next slide. So when you start, again, it could be very general. They may not specifically come in and ask about anything with gender identity. So in your review of the medical, surgical, family, and sexual history, some concerns may come out. If they do talk about or ask about hormones, then a question may be, why don't you tell me about your gender journey? Or how would you describe your gender? Or how long have you not identified with your gender assigned to you at birth? And then talk a little bit more about what are your goals for this visit. Sometimes not everybody wants to take hormones. Sometimes just having someone acknowledge and accept them and be willing to have the conversations and talk about it is enough to start with. And I have had patients who have been on hormones and choose to go off, and others who, don't want hormones, but they want somebody who is affirming of who they are. You could ask, do you have any discomfort with any aspects of your body? Is there a support system? So do they have friends or a community where they feel supported? Because that can be sometimes very helpful, especially if you're going to be starting hormones. I usually ask if they feel safe at work and at home. Again, many of these patients experience bias and other issues. While seeing a counselor and having gone to therapy is not a prerequisite for doing hormone therapy, many, as I mentioned, have anxiety, depression, or a higher risk of suicide. Many have been in counseling, and sometimes it's their counselor that tells them to please seek out medical care because they've identified them as trans and they want to pursue changing. Next slide. So again, a few more caveats. Always be respectful, be non-judgmental, and that includes what shows on your face. Do not label or make assumptions. I usually ask how patients prefer to be identified. Some of my patients just want to say, call me a woman or a man, not trans woman or trans man. So I think it's important to, and I usually note that, what their preferences are. Use an ask listen approach, and verbal and nonverbal communication should always be professional. I always ensure that the record is confidential. And so if there is something they don't want me to put in or type into the record, I will respect that. Unless it is potential harm to a patient not to know, say, about a medication or something that they may be taking. Next slide, please. So in terms of preventive care, again, so this is where it can be a little confusing. The cancer care screening needs to be according to their assigned gender at birth and depending on which of their body parts are present. So if a trans male has not had removal of the cervix, then they still need to actually have pap smears done. And it's according to the usual guidelines for an average risk individual. Again, a trans male may also still have breast tissue, and so they may need a mammogram. A trans female will still have a prostate because those are usually not removed with any surgery, and so they will need to have prostate cancer screening discussion when the timing is right. And if they are on feminizing hormones, then at a certain stage, they will need mammogram screening. Colon and lung cancer screening are per the usual guidelines, regardless of gender at birth. And then the usual screening tests for HIV, hepatitis B, hep C, and other STIs or giving PrEP really are not based on what their gender. Vaccinations are per adult vaccine guidelines that you can look up. Next slide. And again, just to reiterate, there may be a few little tweaks for patients who are on hormones and transgender. Breast cancer screening for a trans female is if they are on hormones and have been for at least 5 to 10 years and they are average risk. Again, high risk individuals are screened differently. If they still have a cervix, cervical cancer screening can be very painful, especially if they've been on hormones. And so again, you may need to pre-treat with some vaginal estradiol, and you need to make sure you tell the pathologist that the patient is on testosterone because they need to know that because it may look different to them. And so you don't want them coming back saying can't read or, this is abnormal or something like that. So your pathologist needs to know. It's unclear about calculating cardiovascular risk. So sometimes people sort of take an average between the male and female calculators, and based on family history. Next slide, please. So let's start talking about the patients. Let's start with Joy. So Joy comes into clinic, 36-year-old. She's assigned female at birth. She has a longstanding history of depression and anxiety and is already on venlafaxine and buspirone. She tried counseling and therapy, didn't find it very helpful. Her PHQ and GAD are scoring in the severe range. You discuss suicidal ideation, but denies. And at that visit, perhaps you increase the buspirone a little. And on the way out, ask, do you prescribe testosterone? So what should your next plan be? Let's go to the next slide. So a couple ways to approach this. Most of us will not have time to sit back down and then explore gender identity issues. But walking out the door without addressing that question also is going to be a little problematic. So many times what you could do is don't dismiss that question because of lack of time, but perhaps take a moment and say, thank you so much for feeling comfortable asking me that question. I don't have time today to discuss that, but why don't we get you back for an appointment very soon? And we can explore that question you asked me in more detail. Would that be okay with you? If you have time, like your next patient canceled, and you want to explore what that statement meant, then you certainly are welcome to do that. I just, for almost anything hand on the door question, it's usually nice to have a plan to try to address that as soon as the patient desires. Next slide, please. So the patient comes back in, and you've now asked a preferred name and pronoun. And the patient's preferred name is John and prefers the pronouns he, him. And John started having gender identity issues, starting with puberty, which is actually quite common. And it was much worse during menstrual cycles, and has been reading about transitioning on the internet and appears very knowledgeable about the hormones, but does appreciate having a informed consent discussion. And I'm very happy to have found a clinician willing to work with him and be open to gender affirming hormone. So what are the next steps? Next slide, please. So here are some of the criteria, and this is based on the WPATH, and I'll tell you what that is in just a moment. Guidelines for beginning gender affirming hormone. So somebody who has gender identity, the incongruence should be continued, ongoing, and is significant. That they have the capacity to give informed consent, that therapy is not a requirement, but is an option, and that patients are certainly able to decide what is best for themselves. Again, I'm talking about adults. If they do have mental health issues or concerns, then that should be addressed. And then talking about the side effects of the hormones and any possible impact on fertility. And you still need to discuss birth control options because, again, hormone therapy doesn't always stop fertility, but it can change it. Next slide, please. So the WPATH guidelines, again, these have changed a little bit, but someone needs to just meet two out of the gender dysphoria. And again, I mentioned that not every patient has gender dysphoria, and they need to have had at least two of these characteristics for 6 months or more. So these are pretty much some of the things I've already discussed, that they have a strong desire to have their sexual characteristics from birth modified or changed, that they have a desire to be the other gender or transform into the other gender, and that they want to be seen and treated by society as their preferred gender. Next slide. So WPATH stands for World Professional Association of Transgender Health. They do have several guidelines, standard of care. They've got a very comprehensive booklet. I have given you their link at the end of this talk. So certainly I would explore more of what they offer in terms of, again, language, setting up visits, and your room. I'll get to your question in a minute, Shayna. Thank you. And again, I think it's important that you need to discuss the goals of care. Again, doing an appropriate history and physical exam. I also make sure that a patient is comfortable with me touching their private areas first and not just assume that it's okay. So I will always ask permission. If I can look at how their hair is distributed, if I can look at the genital area when I am doing their exam. It is not essential necessarily to do a genital exam before prescribing hormones, but it helps me sometimes to know if the body changes with hormones are being effective or not. Before starting any hormones, it is very important to talk about reproduction because hormones could change their ability for fertility. So if I have a male at birth and they want to transition, I will talk about sperm banking. For female at birth, I talk about whether they want or may want to get pregnant and do they want to harvest their eggs, or if they choose to become pregnant, go off hormones, not knowing if they will be able to conceive. And you may need to give them time to arrange and organize that before starting hormones. And when I talk about the hormones, it will become clear why. And again, you still need to talk about birth control options. Talking about the potential effects, the desired effects, and some side effects. I tend to give my patients an informed consent form for several reasons. One, I want them to be able to take it home, to read more, to do some research on their own, see if they have any questions. It's not absolutely essential to get signed informed consent, but I find it very helpful because they can sign it, then I know they've read it, and I just have that scanned into the chart. Next slide. So let me get to your question. Shayna, you said, if the results of pap smear in a transgender male on testosterone therapy, so efficient sample, you could do HPV testing alone. That would be an acceptable option in this case. Testosterone can absolutely change the cervical cells to make it challenging. Again, you could also talk to one of your gynecologists who may do transgender or know about that to see if they have any other things that they do, but certainly doing HPV would be acceptable initially. Thank you for the question. So initial labs, and these should be obtained before initiating hormone. A complete blood count, because testosterone can actually raise the hemoglobin and hematocrit. I tend to get a complete metabolic panel because I do like to know what someone's liver function test is and any electrolyte, a testosterone level, which is total testosterone, not a free. I tend to start with an estradiol level, but it's questionable whether you need to keep monitoring that. An A1C lipid profile and STI is per guidelines and risk. And then we also already discussed the prevention screening. And please remember drug-drug interactions. So there are websites that you can use to look for interaction checkers. Next slide. Again, you don't, I tend to get signed informed consent, but again, that's just because I print out the form so a patient can read it and they can come back and have a discussion about any questions. They need to understand that several of the changes can be permanent and non-reversible, and that they need to know that starting hormones carry certain risks and that they can accept it. You can download consents from Fenway. Next slide. And this is what they look like. There's one for masculinizing hormones and one for feminizing hormones. Again, that talk about a lot of the changes that can be occurred. It will talk about what may be permanent and what may be reversible. Next slide. So let's start with the side effects of masculinizing hormones. And what I've done with this table is I've put in how quickly those changes can start and how long it may take to get maximum effects. And I think this is very important to tell patients, because many patients feel that once they start hormones, they should be seeing changes immediately. And for a lot of patients, it doesn't happen immediately. It takes time. So I'm very careful about increasing my dosing based on early changes, because the early changes may be very minimal. And again, the maximum effect of hormones. So if they've been on hormones for a few years, going up on the medication doesn't make any sense, because they likely will not get any more benefit, but may have increased harm. And then in that column that says reversible, where we have data, some of these are reversible and some are not. So with starting testosterone, they may get more acne, oiliness of the skin. The fat redistribution can take several months to change. Most of those are reversible. Cessation of menses may or may not happen. And I have seen several patients on testosterone that still continue to have menses that can be quite devastating. And so discussion about, do they want to pursue surgery or some birth control option that may stop their menses. Again, that's not also guaranteed. Clitoral enlargement will occur, and that is not reversible. Libido may change or may not, and it may increase. Vaginal dryness and atrophy also occurs. Facial and body hair tends not to reverse. And again, hair loss, so male pattern baldness also does not reverse. Muscle mass changes, increasing muscle mass is a reversible condition. Deepening of the voice may occur and is not reversible if it does. And then again, in terms of fertility, it may be reduced. We don't know how reversible that is. It may be possibly reversible, but it's unclear. Next slide. What are some of the risks? So definitely some increased risk of polycythemia, and that's why you need to monitor the CBC. Acne is very common. Male pattern changes. Again, if they do have increased polycythemia, sleep apnea can occur. Elevated liver function tests might occur, and there are some forms of testosterone that can do that. We don't really know about increased risk for hypertension, cardiovascular disease. There's differing data on testosterone and its cardiovascular risk. And then we don't really have good data whether there is any increased risk in terms of specific cancers. Next slide, please. Sorry, I saw a question. Hold on. Yes, male pattern baldness can still be treated, and you would treat it similar to you would treat any patient with that. So in terms of what masculinizing hormones, so you usually start with lower dosing. So what I've given you on the initial dosing is what would be considered a low dose start to minimal dose, and then the max dose that you should use. In terms of what is usually more affordable for patients, the injectable testosterone, and that would be testosterone cypionate or testosterone ethanoate, are usually more affordable and are usually easier to get. They may still require prior authorization. And again, they can be given weekly or every 2 weeks. You may just need to modify the dosing. There are topical testosterones. There's 2 different gels, 1% and 1.62% that typically go on the upper arm. There's a new axillary gel that's probably more expensive since it's new and comes only in one form. I had a question last time I gave this talk about testosterone undecanoate. Oral at this time, you may see it in some guidelines, but it really is not yet available. And due to some higher risk that was seen in other countries, There is an injection form of that, but it is available through a restricted program only. And from what I can read, what I could find on that data, it is not better than any of the other forms of testosterone, certainly not better than any of the other injection forms, may be more expensive and may have higher risk. So I would question why that would be used over anything else. And there, again, was a testosterone patch. It's no longer appears on the UCSF guidelines, and those are the guidelines that I tend to use and look at most because I think they are evidence-based. And I think they do a good job explaining why those particular medications are listed there. Next slide, please. So if you are going to prescribe injection testosterone, you can write the script. You may need to wait for a prior authorization. You also need to make sure that you prescribe needles. That would be needles for drawing up the medication and smaller needles for the injection. You need to give them a script for the syringes and, of course, a needle sharp spin. There are some really nice videos if you don't have a nurse who can show patients how to do proper injections. A lot of times I will have patients come in to do a practice with the nurse in terms of how to do those injections. Next slide, please. So what is the follow-up? I tend to see patients at a month just to see how they are doing, if they're having any problem with the hormone. And then every 3 months for the first 1 to 2 years, as you may be changing your medication dosing. Labs are typically done at 3 months, and you should be getting at least a CBC and a total testosterone every 3 months. If you are concerned or if they had slightly elevated liver tests, I might also repeat those to see if there's been any changes. In the current UCSF guidelines, repeat estradiol testing is not necessary. And when you look at what goal of testosterone do you want to go for, it's usually in the normal male pattern, 400 to 600, but you can individualize that a little bit. Some patients only want a little change. They don't want all the changes and they don't want to go up to the maximum dose, and that's okay. So you don't have to keep increasing the dose. So you want to, again, guide it to your patient and individualize that. Once they are on stable hormones or have reached the maximum dosing, then you can do testing every 6 to 12 months after it's been at least a year of that. And again, you continue to do the routine prevention screening per the U.S. Preventive Services Task Force guidelines. If they get pregnant, you have to stop testosterone. It is absolutely contraindicated to continue testosterone. It is teratogenic. So that needs to be stopped. So that's why having a conversation about birth control up front is really important before beginning this therapy. Next slide. So now let's go to Susan. So Susan is coming to see you to discuss gender-affirming hormones. She's 36 and has thought a lot about this next step. She was assigned male at birth and only recently had health insurance and prefers the she/her pronouns. Does have past history of hypertension, tobacco misuse, and depression. Her current medications are amlodipine and sertraline. On her exam, her blood pressure was 140/90, scores in a PHQ of 10, does have male pattern on the hair, chest, and abdomen, wants to start hormones, has validation from a prior physician on gender identity and has all the records with her, has seen a counselor in the past but not currently, and feels that her depression is well controlled. So is she eligible for hormone? And do you have any specific concerns? Next slide. So yes, she does meet the criteria. You have documentation from a prior physician about her gender identity, and you could consider hormone. Of concerns for Susan would be increased risk of DVT or PE given if she is still currently smoking. And so smoking cessation counseling would be really important. It is not an absolute contraindication, but is an increased risk. We don't really know what the risk for breast cancer is. Blood pressure treatment would be important in making sure that blood pressure is well controlled. And again, still, if 36, so still want to discuss fertility and birth control issues. Next slide, please. So again, you do want to get a complete metabolic panel, a CBC, a total testosterone level, and estradiol level. Again, A1C and lipids per guidelines, STI testing, prevention screening, as we mentioned. And again, always remember drug-drug interactions because many medications go through the cytochrome P450. Next slide, please. So here's some of the side effects for feminizing hormones. Again, I've done the same thing for how soon you may see changes or onset in some of these changes, how long the maximum effect may be, and whether it's reversible or not. So again, fat redistribution changes, so they may have more of the pair. They will have decreased muscle mass, softening of the skin, decreased libido. They may have decreased erection, and all of those may be reversible. Breast growth can occur, and that is usually not reversible. Decreased testicular size is usually not reversible either. Decreased hair growth tends to be reversible. And again, decreased fertility, we don't really know. That's a maybe. Next slide, please. So some of the risks, again, feminizing hormones because they use estrogen typically are at increased risk for DVT or PE. Same risk as it would be with anyone going on estrogen. Gallstones, elevated liver enzymes, hypertriglyceridemia, weight gain. If they are on spironolactone, then hyperkalemia or renal insufficiency. Maybe there is increased risk of cardiovascular conditions. Hypertension and hyperprolactinemia can also occur with these meds. We don't really know if it necessarily increases risk of type 2 diabetes. And again, the data is inconclusive right now for increased risk of breast cancer. Next slide. So here are some of the options. So we tend for feminizing, we use the feminizing hormone, which is estrogen. And then you may use androgen blockers, which are different medications. So the feminizing hormones, again, oral estradiol can be used, but in someone who is older or who has any higher risks, I would probably stay away from that because that may have higher risk of VTE or DVT or PE. There are transdermal estradiol patches that you can use. Again, the patches only go up to a certain amount, and so sometimes it's hard to have multiple patches, but that may work in someone who uses a lower dose. And then similar to testosterone, there are two types of injection estradiol, valerate or cypionate, and the dosing that you have is there. And usually it's every 2 weeks. Again, if you're going to do it on a weekly basis, some patients prefer that. You cut the dose in half and then monitor that way. For androgen blockers, probably the most common used is spironolactone. And you start again low. You need to monitor their potassium and their renal function given that medication. For patients who, again, have hypertension, that may be a very good option because it can be used in hypertension as well. If they don't tolerate spironolactone or don't like the side effects, then either finasteride or dutasteride are options, and I've given you the dosing there. And those block some of the androgen from a different cycle than spironolactone. Next slide. So there are other feminizing hormone you may read about, and I tend not to use these very much because the data is not very good. I do have some women who have been put on progesterone, and if they have done well and they feel that it has helped some of their symptoms or side effects or getting some of the changes they want, I will leave it as long as there are no contraindications or adverse effects. And the two types of progesterone are either medroxyprogesterone acetate, which goes by trade name Provera, or micronized progesterone, which goes by the trade name Prometrium. You may also read about some other hormones, such as bicalutamide as an androgen blocker, or cyproterone. And again, I cannot find any data that the bicalutamide is any better than anything else, and maybe higher. It is not in the UCSF or several other guidelines. Cyproterone actually has some cases of fulminant hepatitis, and again, has absolutely no benefit or advantage over anything else. A GnRH you may see in some guidelines, but again, not used in adults and is not in the UCSF guidelines. There was a question, can finasteride be used? Yes, finasteride is a treatment for male pattern baldness. Next slide, please. And just some risk for oral estrogen versus transdermal. As you can see with this plot, that transdermal hormone is basically doesn't have necessarily any higher risk for VTE. However, oral estrogen does. And if you add progesterone, that can also increase risk. So when we are talking about Susan, since she already has a higher risk for a VTE or PE, I would not add a progesterone for her, even moving forward. Again, if she continues to smoke or has any other risk. Next slide. And then we don't use conjugated equine estrogen. So you should note that when I stated estrogen, it was estradiol, not conjugated equine estrogen, because that has a higher risk, again, of VTE or PE. Next slide. And what is the testing? Again, I tend to see my patients at a month. If they are on spironolactone, and many times I will check a follow-up complete metabolic panel to make sure I look at the renal function, the potassium, and the liver tests. And then again, you want to get labs every 3 months for the first 1 to 2 years. And then if they are stable, that can basically be moved out a little longer after that time. I don't necessarily change the dosing at every single visit. So again, it's a combination of what are their labs doing? How are they feeling? What changes have they had? And remember that table that I showed you about how long it takes to get those changes. So again, you may need to just sort of reaffirm with patients that, yes, if their dose levels can tolerate going up on the medication, that's fine, but it's still going to take time to get to some of those maximum changes for them. So sometimes the dose is changed at the 3-month visit. Sometimes it's not, depending on what else is going on and what your labs look like. Estradiol and total testosterone levels done again at 3 months. Renal function and potassium, as I mentioned, if they're on spironolactone. Prolactin is usually only done if they have symptoms, like if they have galactorrhea or other symptoms that would make you think of high prolactin levels. We think trans women are higher risk for breast cancer than cisgender men, but we don't actually have a lot of data for that. And again, if a patient has silicone fillers or other implants and they're on hormones, you may need to ask your radiologist what would be the best screening modality for breast cancer screening. Let me just, okay, so the question is, what advice should we give patients regarding testosterone supplements? Let me get back to that question in a minute, if that's okay, Joseph. We can talk about supplements in general. Next slide. So here's where we need more data, is what is really the overall risk with gender-affirming hormones and which type of estrogen? What's the overall risk of obstructive sleep apnea or cardiac issues for patients on testosterone? And then what do you do if somebody actually has a complication that may be due to the hormones, like a PE or DVT, if they've had a cardiac issue, if they have significant elevation of liver tests. And so this is where you probably want to reach out to your subspecialists as well, and really use a team approach for what to do. And it also needs to be a discussion with the patient. So I had a patient who had a significant cardiac issue, and we had to stop the feminizing hormones. And it took a long time for them to get better, and then had a conversation with the cardiologist, myself as primary care, then a endocrinologist, about whether it was really, and the patient about whether, the risk versus the benefit of restarting those hormones. And ultimately for that patient, we chose to remain off the feminizing hormones, the estrogen specifically. So all the time monitoring. They did still have some of the body changes that I mentioned that were not reversible once they started the hormones. Next slide, please. I didn't want to necessarily talk about surgery, but I just want to state this, that many patients want to pursue surgery. And we may be getting more patients with more physicians with more expertise on some of these procedures. A lot of times I have found, and this may change over time, but I have found that surgeons want patients to have been on gender affirming hormone if they are going to take hormones for at least a year. And I think that seems reasonable, as I mentioned, how long it can take for the body changes to occur with the hormones first. Before they will consider it. There's also a long process for getting approved for these surgeries through insurance. And so there are different types of surgery. Usually these are considered top surgeries or bottom surgeries, for lack of a better term. And again, probably the more common ones would be for masculinizing surgery, mastectomy, removing the breast tissue, or hysterectomy. There are also surgeries that would transform into an ability to have a penis equivalent for feminizing surgery, breast augmentation. And again, there are also bottom surgeries to reconstruct a vagina. So again, these require specialty care, preferably physicians who have expertise in this, because there can be many complications from these surgeries. There are also facial reconstruction, tracheal shaving, and other surgeries. Speech therapy is also something you could offer patients that is not surgical, to try to get their voice to be changing, either higher or lower, depending on what they want. Next slide, please. So just to summarize a few things, again, transgender patients are definitely at high risk for avoiding or delaying care, and that even includes just general preventive care, even if they don't want to discuss hormone. So we can certainly help them by being open, respectful, and a welcoming environment. Feminizing and masculinizing hormones can be initiated in primary care after discussion of the risks and benefit. And please remember to talk about fertility before starting any hormone. And then don't forget the normal primary care based on their gender at birth and depending on what body parts they still have. Next slide. So here are some of the resources, and I've given you links to a lot of these guidelines and some of these other information that you can have. There's also some other training modules if you want to look into some of those. And we can stop sharing the slides, and now I will get back to